A 64-year-old male patient was brought by his daughter in a state of unconsciousness to the casualty where he was admitted, and he was evaluated with CT brain, which showed um, interhemisperic SH more towards left side and with IVH. So he was taken for CT brain angio, which revealed a anterior callosomarginal artery aneurysm along with left parietal AVM. With these findings, he was taken for surgery and he was planned for left parietal decompressive craniectomy as there was a large bleed and there was brain edema which is seen. So, in order to prevent post-operative increase in ICH, we have planned initially for a decompressive craniectomy. So, he is kept in supine posture with the head slightly flexed and in neutral position. So standard FTP craniotomy with the slight extension to the opposite side exposing the superior sagittal sinus was the plan of exposure, and a left FTP decompressive craniectomy was done exposing the superior sagittal sinus. So the dura is opened in a curvilinear routine curvilinear fashion with the dural flaps raised over to the superior sagittal sinus, exposing the interhemispheric area. In the interhemispheric area, uh, there were many vessels that are going directly into the superior sagittal sinus, so the exposure was a bit difficult. So we have to remove the arachnoid attachments and bear out the draining veins into the superior sagittal sinus, leaving as a small corridor into the brain. Once this has been achieved, we started following a branch of this marginal callosal artery which is directly visible, and we could see there are many uh, adhesions around the vessel with a large clot that is present in the interhemispheric area. So we slowly removed the clot and followed the branch of the marginal callosal artery which led us to the marginal callosal artery proper. Once it has been reached, we slowly dissected out, skeletonized the marginal callosal artery up to the aneurysm, where we could find the aneurysm. Once we could find the aneurysm, we started applying a permanent clip, and suddenly it has bled out severely. So we controlled the bleeding again, and we have reapplied the clip along with second clip. And once that is done, we could achieve complete hemostasis. After that, we checked for the fundus of the aneurysm, and we found that there is a good clipping through and through. So we started proceeding for dissection of the AVM. Left parietal AVM had its feeders from the same callosomarginal artery where there is aneurysm, and MCA vessels were feeding along with a part of posterior circulation with the PCA branch feeding the aneurysm AVM, and it was draining into the superior sagittal sinus, and that AVM is also very close to the superior sagittal sinus. So the AVM is very close to the superior sagittal sinus, and once we could delineate the main draining vein of the AVM into the superior sagittal sinus, we slowly started separating the AVM complex from the surrounding brain with um, arachnoid knife, and we are slowly dissecting out the vessels. As the vessels are very friable, it is very uh, it has to be done meticulously without any bleeding. So the procedure is done very, the arachnoid dissection is done very slowly, and slowly all the veins of the AVM are skeletonized. Once this is done, we started correlating the main feeders, that is from the callosomarginal artery feeder, followed by uh, the feeder from middle cerebral artery and posterior cerebral artery feeders. we slowly started coagulating the AVM, nidus itself, and we have separated it from the parenchyma. The AVM is sitting directly over the motor area, dominant motor area. The procedure has to be done very carefully without damaging any normal brain. Once this is done, the AVM complex is completely coagulated and removed from the normal brain, and the draining vein is also coagulated. Once the hemostasis is achieved, our surgery has been completed, and we close the brain with in layers without the bone flap.